Well, ladies and gentlemen, just look left and right from you and see other people. We all look different. We all look different, but also our hips all look very different. And if we go to literature, we can see that the variation in anatomy is quite big. And you see here especially the variation in offset, comparing all these different studies. Initial studies from the 80s and the 90s with standard radiographs, but then more precise studies with CT scan. And you see that the offset range between the smallest offset and the largest offset reaches 3 centimeters in a big population, even sometimes up to 4 centimeters. There are different strategies to try to restore that offset. One strategy with a standard stem is to align the stem along the shaft and try to change the insertion depth and the neck length using extended and normal standard implants or lateralized and standard implants. The other strategy is to use a strategy of a calcar-guided stem where you want to implant the implant not along the shaft, but along the calcar, taking the calcar as a guide, not looking at the axis of the stem, but trying to align them along the calcar. And in a varus hip, you will have a tendency to insert them in varus, and in a valgus hip, you will have the tendency to insert them in valgus. And as such, you will restore or you will approximate the offset better, or at least that's what we believe. Now, our first research question was, is it possible with a calcar-guided stem to restore the standard anatomical rotation center? Is that possible? And to do that, we took 90 CT scans that we segmented from a healthy population in terms of proximal femur. It were almost 60% males with a huge range of weights. And we first looked at anatomical variation. We looked at 4 parameters: neck length, the offset, the neck shaft angle, and the anteversion. And then we tried to virtually implant in these segmented femurs an optimist stem, trying to have the maximum calcar-guided implantation, but also taking care that we have that we maximized the cortical contact, because we believe that that was important for implant stability. And we might be criticized for that. I know other people want to implant them with less cortical contact, but we put that as really as a priority. And as such, a lot of our stems might be implanted larger than some of you might implant their own optimist stems. Looking at the anatomical variation, we found what literature found, an offset range of about 3 centimeters, but also very large variation in anteversion. You see between 1.6 and 43 degrees of range of anteversion. And also the neck shaft angle there was a huge variation between 107 degrees to under 38 degrees. So a large variation in that population of femurs that we just collected from a database. Now what we measured actually is the deviation from the head center, trying to have what we thought would be the optimal implantation. So the priority was to get stability and see how far we could get with trying to restore the rotation center. And here are the results. On the left-hand side, you have the mediolateral data, and on the right-hand side, the superior inferior data, so the shortening or the lengthening, and on the left side, the restoration of the offset. And you see that taking these constraints into consideration, we had a good restoration of the offsets in most of the cases. Most of the cases were within 5 millimeters, and we put that coming from literature as a target within 5 millimeters plus or less in terms of length and offset. And we succeeded in most of these implantations to do that. We see that there was a small tendency to decrease the offset. We could not reach the offset in all cases, despite there was just a few millimeters. If you look at the sizes that we implanted, we see that there is a large variation in sizes that we used almost the entire gamma of sizes from 1 to 11. I think there are 12 sizes, so the 12 we didn't implant. But you see also that in the smaller sizes, we had the tendency to use lateralized stems, where in the larger sizes, we had the tendency to use more standard stems. And I would be very curious if the people who implant them really, and not only virtually, have the same experience. Would be certainly interesting to look at that. If you look at stem orientation, we actually draw a line that was perpendicular to the tip, to the plane through the tip of the implant, a perpendicular line to the ceiling, and that was the stem central axis. This stem, of course, has no central axis, but we defined ourselves a central axis being perpendicular to the plane which is going through the tip of the stem. And we saw that if we took that as a reference, 66, so 2/3 were in slight valgus, and the other ones were in varus. Also, we used generally either large or medium neck sizes, and in the majority of the cases, lateralized stems. The second question, and it was talked about before, is that often you end up medializing a little bit the rotation center of the acetabulum. And if you want to restore the global offset, the relation between the pelvis and the greater trochanter, you need to increase a little bit by 5 millimeters the offset of the stem. And so our question was, is a calcar-guided stem able to do that, and how does it compare to other standard stems? So to do that, we looked at 3 different stems. The first one is a cemented stem, the CPT stem, Exeter-like, undersized compared to the broach that you use. There are 7 sizes in that implant, and there are 3 offset options: a standard, an extended or lateralized, and an extra extended or lateralized. In total, there are 4 different neck lengths, and 18 stems are available. The centris stem is a curbool-like stem, which is a canal-filling stem. You try to fill up the canal, and the cement is just filling up the small gaps between the implant and the cortex. You have a different philosophy of restoration of offset, with 4 offsets for each size, but a limited number of sizes, and 12 stems in total. And then the uncemented Optimis calcar-guided stem, which has 12 sizes, a standard and an extended or lateralized version, and 4 neck lengths, so 24 implants. We first look at what the offset range would be for these different implants. So we looked for each size, going from a -3.5 to a +3.5 or +7 neck length, how the offset ranged in these 3 different settings. Knowing, of course, that for the Optimis stem, you would have additional variation due to the fact that you can implant them either in varus or in valgus. These are the offset range, and you see that for the CPT stem, with the 3 different offset versions, the range is 33 millimeters. For the centris, it's about 29 millimeters, but it's 38 for the Optimis stem. So it's a little bit larger for the Optimis stem, and that was statistically significant. You can see that down on the table there. We used the same implantation method that we believed they need to be implanted for. So the cemented undersized stem was put in line with the shaft. The centris stem was cemented line to line, and the Optimis stem was cemented along the calcar. Here also, taking into account that this was an uncemented stem and that there we needed a maximalized cortical contact, which was not the case, of course, for these cemented implants. They can be cemented wherever you stop or you want to stop them. They will be fixed at that level. So there are much more opportunities to position the stem in a cemented version compared to an uncemented stem that needs to have stability through direct bony contact. These are the results. We took 50 femurs for that study. So we took, on the left-hand side, anatomical rotation center, on the right-hand side, the medialized rotation center. And we see that the CPT with the 3 offset versions was slightly better than the other ones, than the Centris and the Optimis, and it was statistically significant for the Optimis. And in the medialized rotation center, it was more difficult to compare it to achieve a good result with the 3 stems compared to the other ones. So medialized rotation center is more difficult to reach with all 3 stem types. Here are the same results, but just the raw data. We took a line at about 5 millimeters, which we thought was a threshold. And we see that with the CPT stem, where you have a full freedom of positioning in the in the superior and inferior direction, but also slight varus, slight valgus, also rotationally. You have a lot of freedom there. You can achieve, in all cases, in an anatomical rotation center, which was not the case in 7 Optimis stems. The same was also true for the medialized rotation center, with some high variation there. And I think probably some people would implant the stem then in much more varus, accepting that there would be no full contact over the whole surface and maybe a somewhat less stable situation. And this might be, if coming back to our discussion, an indication for a cemented Optimis there that would have been placed more in varus. So in conclusion, I think for most of our cases, the vast majority of our cases, all 3 stems could achieve a very good result if you want to aim for an anatomical rotation center. But for medialized rotation center, it was much more difficult. Our best stems here from this study was the CPT stem because it's undersized and you can really position it wherever you like along the shaft. You can position it in light varus or slight valgus. You can also rotate it easily within the cement mantle. And for that reason, it performed well. Also, it has 3 offset versions, which is also an advantage, I believe, in trying to restore the normal anatomy. On the other hand, I think as an uncemented stem, the Optimis performed very well because there is a very large offset range of between the smallest size and the biggest size of 38 millimeters, and because you can position it, or you should position it, along the calcar, which you would have a more varus position for a varus hip and a more valgus position for a valgus hip. I thank you for your attention.